will still cover us, but if it's located directly there, they'll take the claim on theirs as we would not have to.
Correct. And one of the things we kept the indemnification and liability in the lease really related to premises.
Right.
And in the MOU, we're talking more about personal injury. And we talked through, SWOPE has an interesting sovereign immunity that I wasn't particularly familiar with, but because they are in receipt, and I'm probably not going to articulate this correctly, but because they receive grant funds or other funding or special dispensation primarily from the federal government, not exclusively, that they somehow carved out a little bit of sovereign immunity because of their affiliation with the federal government. So we got through those issues. The health department is fully protected. I was just trying to help prevent the health department from getting swept up in a, you know, someone thinks something bad happened. I don't really want us to be involved any more than necessary. So anyways, a good partner to work with. I think we're in good hands with this group.
Thank you so much.
You're welcome. Thank you.
I don't think we have an action item on that. Then.
It was just a brief update. You know, I think we have 4 different work groups working on stuff, and they all kind of be trending towards the not much happening, and then all of a sudden stuff is happening. And Dustin may have some things on his report. I'll go ahead and skip to them. But have we sent the mailing out?
We've got some mailing out. So we did, at recognition of Joe, that we discussed last time, like for HIPAA privacy, we want to make sure that all of our patients are consenting, that we do allow them to transfer their records over to SWOPE or to the provider of choice. We've begun already started sending them out. I believe we're keeping them out, and tomorrow we'll take a big load of them out there. But we have like copies of letters that has information about the transition, letter announcing, you know, Janice's resignation, and then as we go in and SWOPE coming in, as well as a request for them to fill a form, return it to us about the release of information, as well as access to do it digitally online as well. So it'll be a task, but I think we'll get there. I think what was it, 1,100 total patients? Yeah.
Did we skip signage on the building? I presume they're responsible for their own signage.
They'll be responsible for it within our parameters or whatever you want to say. But they have not.
As a landlord, we get to approve the signage.
Right. But they have not come up with what they're wanting. We proposed some stuff. I don't know that they particularly liked it, which is fine, but I haven't seen anything back from them either. Which is why I'm saying it's kind of like some of the stuff we give to them, not hear back from them, and then all of a sudden we do.
As long as it meets the city code, because the city doesn't have signage inspectors, they send out people when there are complaints. And if a disgruntled person comes out of here for whatever reason, they can make a complaint. And then as long as we're within the city statutes, we're good.
So we also have to meet our, not subdivision, but the Air World Business Park covenants. And which is interesting just because we're a governmental entity. We technically don't have to follow Kansas City's guidelines. We always try to, because it just is not one of those things where you want to cause trouble when you don't need to. Probably our bigger challenge has been working with Airworld, just on some of their things. And if you notice, everyone's kind of the same. And like we wanted an electronic board, and they kind of went back and forth, and then finally gave us a very hard no about that. So
we come back year after year.
Yep.
Squeaky wheel.
Yeah.
We can do it politely too.
But so they are probably one of the people that we want to just make sure, or entities we want to make sure.
Absolutely. Absolutely. I'm assuming since there's a variation in hours, will there be an ability to secure the rest of the building? Or I imagine you guys have those logistics ironed out, or we'll be working on it.
So the building was actually designed to do that already, because our WIC clinic is actually the
Right.
building closes at 4:30 except for WIC, Monday through Friday, which is open till 6. So normally when we're not having board meeting, all these doors are closed. People can get to the bathroom and to WIC. Well, if Swope decides to extend their hours, it'll be the same thing. The one thing that's going to be different is what they say they're going to start with
2 days a
2
week.
days a week initially, and
Okay.
then they will go up from there. So I don't know if we'll have that problem right away, but they did talk about having some evening hours and different stuff, which I think is great for access. but we'll see.
I speak for myself, and I assume the rest of the board members would be supportive of, we're willing to make any accommodation. If we need to expense money for locks, security, things like that. I don't think we're gonna, I wouldn't try to pass that on to them in the early stages of the relationship. We're trying to accommodate them so they take care of our citizens, and
Yeah, where they are, like, just because of the clinic and how it's already set up, there shouldn't be any expense, just some administrative stuff.
nothing else on that. We're moving on to the EMR data migration. You know, scroll back up, it's above it. Right there. Right there.
And that's the thing that I mentioned. Swope is working with their attorneys to determine need for record releases. They're still working on that.
They did get back. I think they sent an email out that they do, their attorney did recommend them that we follow the guidance that Jill provided us, and that we do get
Yeah.
those consents.
Yeah.
Yeah, so that we do get those consents.
I'd throw out an idea that will hopefully help you. And the data migration doesn't necessarily need to go straight to Swope because you may not have all your consents. Could you not get them to download the data migration to the county so that when they do have patients who haven't signed a consent, they sign a consent, they can put a request in to get those records in real time. All you have to do is get that and you cut Cerner out of the process.
That's how they're sending it. Like so they batch the data and they'll be sending it to us directly. So we'll have access to that, and then we'll be responsible for getting that into Cerner.
Yep, you guys are all
Swope.
over.
But we still have access to Cerner. We will continue that for at least 5 years. Just for maintaining patient records on our end. So we can very easily look at their schedule and know who's coming in and get them those records at a time if the data migration hasn't already begun. So
Sounds like Swope is working on the need for record releases, but it's really, wouldn't it be us that we need something satisfactory? So maybe save them the time and trouble. And if you have one that you're comfortable with, that
So we have the release already designed and done.
Right.
I think the issue is really, they wanted it all batch sent to them, and that's where I'm not willing.
you can't do that unless you've got releases.
Right.
But if you do the legwork in front, I don't mean to monopolize this. If you do the legwork in front and you've got 98% of it, then you can try to maybe give them the batch and carve that out. But I would work on getting Cerner tied down to get you the batch ASAP. And it's a matter of them kicking the can down the road. But I think they should be able to give you the records within 30 days since you own them. So I would push them on that. And if they push back, I'm sure that a encouraging conversation could be had to explain that we want to work with you, not against you. So give us a timeline that has an honest deadline. We'll let you know if we can live with it. But make it a deadline with them, because in those companies, they'll kick that work down the road for other more pressing items until it becomes the squeakiest wheel. So that's my admonition on that subject.
Most of this hasn't changed from last month. Janice is still resigning. We're having a little get together. When, Cindy or Dustin?
it'll be August 30th, 2 to 3. We'll be having it in our little reception area just across the hall there. It's her last full clinic day. Her last actual day is going to be on August the 1st. It's that's our back to school dinner.
Right.
Then, so
Great.
We'll all be a little chaotic then. So we decided to have it on for her last clinic day.
So when is it again?
July 30th, from 2 to 3.
So if anyone's available,
Just make sure a notice goes out. That'd be great.
So Cindy,
I can't make it, but
can you make sure that you send that to the board as an appointment? They can decline it, but at least it'll be on their calendar. Uh, sorry, I'm taking notes, so I can remind her. Can you go back up to the numbers? Not much has changed. If you look at the trend, we're pretty much where we've been, which is the whole impetus behind slope. So we are close to, I guess we'll have about one more full month of seeing. Then we're going to have a 2-week hiatus for the transfer. And during that time, people will be able to go to Slope. They'll be able to become a new patient. Slope is well aware that that's our messaging to folks. And so they may not have their first Platte County Health Department location visit here. It may be something else. But when they do come here, they'll already be established and know how everything works. And I believe they're going to try to get them even the same providers. So it should be pretty
Hey,
seamless.
Andrew. Sorry to interrupt everybody. Sorry I'm late, but it is.
Oh, it's my fault.
It's okay. It's okay. Hey, so question for you. Have we got any feedback from any of our clients about the switch to Swope? Are they excited, ambivalent? Like, where are they in the grand scheme of things?
I'll let Dustin speak to that.
I haven't heard a lot of feedback. I know that, several patients, they've worked with Janice for several years and she has informed them that she is resigning. So I think they are a little sad about that. And the familiarity of everything too. That's always a transition for any patients. But I think some of them do know Swope, and I think some are excited. I think some have been with Swope in the past and they're less excited. So it's a pretty good mixture of everything in there.
will our website reflect the relationship with Swope and services so that when citizens of Platte County are looking to get help online who haven't called, they'll be able to see, oh, I can get an appointment here. This is the de facto location for services that the Platte County used to provide that is now being managed and operated and executed by Swope. I thought that might be.
Yeah, it'll be linked right to them.
Yeah.
It'll say some disclaimer thing about, primary care services are available from Slope Health. Click here, or it may not even be a click. It may look integrated.
I know you're all over it. I'm sorry. I'm just throwing out ideas as they pop into my head.
But Dr. Kingsley, the only difference I have, and it's kind of just emphasizing what Dustin said, the only thing that I've actually heard, and maybe Cindy, you have heard other things, just not having Janice or Dr. Parker as their provider like they're used to, which anyone who has had a, clinician that they've gone to for years, no one likes change.
Right.
No.
Did you tell the families and such that, we really did push hard to have them stick around. It's just, it was their personal decision to move on, right?
I don't think we got into it that far. I just think that's kind of a touchy thing. So
the executive team and the board have been very supportive to maintain continuity and encourage that transition. Swope was on board with it. The individuals involved have made decisions that are best for them and their families is the way I perceive it.
And
that's reasonable to share with the patients too when they're disappointed about it and stuff. If they know it's the provider's decision, I think that goes a ways too as far as them feeling comfortable with continuing care.
Right. It wasn't for the lack of our trying to do it.
Yeah, I think that's important to.
And I do know she has been having a conversation with her patients that come in because she wanted the chance to say goodbye to a lot of them. So she has been letting them know that the transition was occurring and that that's the first question they normally ask is, are you going to be my provider still? Yeah. And it's always, I'm either waiting my decision and then we'll see how things go. So, but we do have that information on our website as well, like the fact sheet, the letter we send out to patients, all that's available on there. We'll have that information once they try to get their appointments scheduled for Swope.
Great.
You're
And
giving
Dr.
them far more
Parker's-
information than typically received in a primary care office.
And it's
Good
usually
story.
True.
well, we won't digress into all that.
Well, I'm just saying.
I agree with you.
Yes.
So Dr. Parker's still going to be our medical director. She's still going to have involvement on the public health clinic side.
Great.
So she is still, and she will be helping us with our TB and complicated STI cases. So, I mean, nothing like that part is staying the same.
And our tuberculosis up.
Right. Yeah. The other one. So
Yeah,
yes, thank
we
you.
wouldn't get to it.
I do have one comment, I guess, that we might want to keep our thumb on, but I have heard several comments from clients who have just expressed a concern that have been this woke and the timeliness of being able to get appointments. Because of, we've had the luxury of not having full schedules all the time. You can call and get in, really quick, sometimes same day. So that's just a frustration. That's, I've already heard,
Okay,
at the front desk has heard.
we, in the relationship, correct me if I'm wrong, there was language that we are even though they're standalone entity, was there not some language about complaint management that and maybe I'm glad Jen's here, because from a legal standpoint, while we're not the provider of service, we are responsible. We have felt responsible that we need this sort of a primary care access clinic. And we're responsible for doing that. But if they're really going to be standalone, we really don't have a role in monitoring that, except
We ask for reports
Mhm.
and they will be giving
and
us.
they're
the
going to go ahead
reporting.
and follow through with that.
And I believe we asked for complaints.
I think we did as well, and that's the other reason why we kept the lease separate from the MOU, because
Right.
you can't really terminate the relationship and a leasehold on that intangible, but they are interlinked. So that is something we hope we never come to, but certainly there's.
Well, I'd like to bring up a couple items in closed session on that topic. I'll make myself a note.
But we do know that it is going to be different for folks.
Yep.
And some of the things where they had a luxury of getting in same day, and that may not be exactly how that works. So we'll see.
I do know, I think that's why they're trying to have that same provider. I think it's in Riverside is their one location, and they're trying to have the provider who's there like 2 days a week, then over here 2 days a week, and try to that way they have each of those days covered throughout the week.
And if someone is needing to see someone on a day they're not here, and
They
they're
can go,
willing to
yes,
go there,
yes.
they can maybe go there if there's an open, is how it was described to me.
Yeah.
So
It makes sense.
can you scroll down?
Thanks for sharing that with us.
Hey, Andrew, can you go back up just a titch, just not too much, just up. So where the network thing, I thought it was kind of interesting. Go down farther.
They're bringing their own fiber in.
Keep
They
going,
are.
keep going. Yeah, so the patients will utilize the health department's guest network, but doesn't Swope have a even like better computer system that they're putting in than we do? That they just don't have the bandwidth for that, or they just don't want to deal with it, or what are they thinking on that?
So they couldn't get better than our bandwidth. They
We have
will,
superior to them. Wow. Okay.
but they are going to have their own fiber connection coming in. I
Right.
actually met with United Telecommunications or something yesterday. So 2 people from their infrastructure group and then Swope was here yesterday to look at our computer room and look at where the fiber would come in. They will basically just follow it. Like we have 2 lines coming in. They'll follow the one that's on the west side that comes from where AT&T used to come into this building. There's conduit ran, so they just need to run a cable.
Yeah.
And I asked them not to rip our cable.
Yeah, yeah, that'd be nice.
But beyond that, they'll come in, they will put their switches and their modem, for lack of a better word, into our rack, but it will be totally separate.
Yep.
The one thing that I did talk to Swope about initially was, and this is what you were talking about, Dr. Kingsley, is that's great. You guys want your own secured stuff, everything. So there's no possibility of it crossing over or us being able to hack in. It literally would be no different than if I was at home trying to hack in.
Yep.
I'm fine with that. But on the guest network for patients and stuff, do you really need your own dedicated thing, or can they just use what we have? We have plenty of bandwidth to support that. There's signs up already. I think it'll just be confusing if we have two public networks. And that's what you were talking about,
Absolutely.
Dr. Kingsley, is we'll share that.
Makes sense.
Okay, I'm fine with that. I was just curious how that was all working out.
Heck, I do it for my tenants at my building. Just because it saves me the headache of trying to put in more.
And we actually have a lot of patients, clients, visitors, they hook up to the network, they see the sign, and mainly it's because their cell service, whoever their provider is, may not have great signal. Sometimes their phone's older, doesn't work well in here. You're trying to pull up insurance cards and different stuff. You need it to be fast. So it does get used. Stop there, if you would. Thank you. We're going to be talking about at least part of this in closed session, but you should have and I think you have it via email, Dr. Kingsley, but you should have a printout basically from John Alvarado from Straub talking about some of the HVAC continuing issues. After our last meeting, we actually met the very next morning. It was already scheduled with the general contractor, his two subcontractors, the engineer, and the architect. And so over the past month, they've been here nearly every week for sure, not every day, but they have been here probably more days than they haven't been. Dr. Chaffee, you wrote me an email. I shared that with them at the end of that meeting or towards the end of that meeting.
Where?
I'm not sure that didn't. I think they were already working on stuff.
I was communicated to directly regarding that.
Okay. But it didn't hurt spurring some stuff along.
As I was told.
But
well, for full transparency, as I campaigned on, I am currently working with Hales at another building, completely separate. And in a discussion, Richie and Bill, who have been out here, brought me up to speed on this. So when I saw your email, I was already brought up to speed.
Yeah, Richie was sitting next to me when I read it.
He told me. Because they were concerned that the board was viewing Hales in a negative light, which I reassured them that I only spoke for myself, not for the board, but I said, it is clear you followed through and executed the plans as designed and fulfilled your obligation to the general contractor. The Board of Trustees is aware of it, and if not, I will make a statement at our next meeting, which I just did.
So, well, at this point, I believe we do have most all the installation type things, whether it be the RTUs, the exhaust fans, window and door sealing, all those types of things were, we actually did in the past month have quite a few things to work on, correct, fine tune. We still have another balance monitoring since so many things have changed since those things that happened last year. But
I'd love to jump in and just share my thoughts with everyone. This is a very thorough email. I want to remind everybody of the conversation we had with Mr. Ruoff here, I think in May or June. The issue a year ago, May, June. The issue at hand is that the architectural plans and the engineering designs had the presumption that there was a control system in the building already. That control system actually was located in another building. When this was sold separately, the plans didn't change as far as the HVAC control systems. So the engineer had assumptions of a control system that could modulate different RT units and work them in concert, which they don't have. It's my opinion that that is the Achilles heel of the problem, or the proximate cause to it. And I think it's vetted out in this email. So we can have further discussions on this in closed session, but I want to make sure everybody realizes that I think this was a design, in my opinion, and having exhausted reviewed this, and my opinion is consistent with gentleman from Straub, Mr. Alvarado, that this is not a contractor or a sub issue. This is a design flaw that is not able to remove humidity from the air very well. They are having discussions with Train about putting in heating strips into the AC lines to remove humidity. And that's going to be a problem that it's not a very efficient solution. I think I'm going to be on record here that it's my opinion that this is a design flaw, and I think further expenses from the citizens of Platte County will be like squeezing water out of a rock. At least that's my thoughts. And when we get in closed session, I'll have more direct suggestions.
Hey, Andrew, could you kind of give us just kind of for posterity's sake, just kind of what the actual humidity issues are so that it's on record?
So in general, kind of the top limit of humidity you'd want is 60% relative humidity inside. And that's the top limit. Optimum is probably anywhere between 40 and 50. But if we were consistently under 60, I don't think we would be able to say a whole lot. Right now, we actually have, so they've done a lot of work, even doing work up to last week. Just looking right now, across the hall, it's 57.5. In here, it's 62.1. 63 down the hall, 54 in the 50s and 60s throughout the building. Far improved from where we were even a week and a half ago, where we were 80 to 90%. Now,
so what is the level that we're supposed to be at? What is our target where we want to be?
Below 6 feet and really between 40 and 50.
Right.
And
So go ahead. I'm sorry.
62.
So any place below 6, like 60 is the absolute max you want to be at. We have, paper that sticks together and different things. You do anything, you start sweating. But below 60, it basically is where you want to be. We haven't been that until actually like today, this week is some of the first times we're starting to see below 60 routine.
It's also cool outside.
It is, but that actually has been worse because the units aren't running. And if the units aren't running, they're not taking any moisture.
Okay.
So this is actually spectacular.
Okay.
There is progress. What left, I mean, and I know in the email, Train had sent mechanical people out. They are now sending their controller people out next Tuesday to see what else can be done. Then they'll be.
So I just want to clarify though. So we're a year old now, a little bit over a year old, and just this week we finally got to close to the target range where we're supposed to be. Is that right?
That is true. Do keep in mind for like 7 or 8 months, because of winter and different stuff, it's really hard to tell. And I will say, when we were going through winter, our humidity levels were fine. Yeah. And you had asked me about that, Dr. Kingsley, whether we needed humidifiers to put humidity back into the air if we were getting dried out. the heating was fine. It did not dry us out. We were acceptable in the range.
Yeah, that'll be interesting to see if we get this fixed, right? And then in the winter, it's so dry, we need to add some moisture. So, I mean,
That's an
indoor
easy-
HVAC
That's a
stuff,
less
you know, I mean,
expensive fix. That's a less expensive fix than the other. Because,
Yeah.
all right. Well, we should probably, if it's okay,
Took
without
me a year to get
objection,
this, I don't know.
move on from this
Yes, yeah.
topic.
Yeah.
As we're gonna address it in closed session.
You know, really in the closed session, I want to make sure we talked only about the legal aspects and we got kind of
Okay.
all the other things out here. And I think this is a pretty good discussion to put us where we're at
Well,
Okay.
on the issue.
So I'll cut to the chase. The problem is the humidity and it's a design flaw. So we have to have dehumidifiers in some way, shape or form, whether we have temporary ones, portable ones. You know, in the interim until there's a solution deployed. I would be very supportive to expense funds for the rest of the summer if we need some temporary portable or temporary positional dehumidifiers to do what we can for the staff. And we'll have the discussions about holding our contractors responsible for having a well-designed functional system.
Yeah, I would say, you know, at this point right now, with the changes that we made and seeing I mean, we're talking about 20 to 30% decreases seen just in a couple weeks. That would have probably been.
Andrew, it shouldn't have taken 14 months to get to that point, though. That's my big bone of contention.
And
I
I guess
I applaud that it's improved. I think that's great. And it's great for our employees, but it should, like I said, I treat this place as if it was my house. I would be livid that it's taken 14 months just to get close to a target where we're supposed to be.
Oh, don't misunderstand me, Dr. Kingsley. I'm not cheerleading the fact that it's good now. What I'm saying is it's so much better that I don't know if the dehumidifier solution is really necessary right now.
Okay.
That makes sense.
It's the perception of the situation. that
Right.
improves that.
Yeah.
Just try to be supportive to make sure
I get it.
have that in mind while we work for a final elegant solution.
Right. Go ahead. So just real quick on the budget, we are at the end of June. That was halfway through the year. We were 50% of the year, 79.2% on our revenue. On our expenditures, we were at 47.3%, so just under. So we're right on target for the year. If you look at our money market balance, we are about $434,000 more than we were last year at this time. Our interest rate, and I know our finance committee chair will be talking a little bit about some of the interest rates and some things we're looking at during her report, but money-wise, we're steady and climbing, and we're working on our reserve accounts and different things that got approved last month. So financially, we're looking good. We did make the payment that we had talked, that the board approved to pay up all the extra principal we were going to pay for our lease purchase agreement. So that's been made. We're not paying interest there. So every penny we're making here extra is being compounded by the fact we're not paying some interest other places too. I'll go ahead and cover Dan's report briefly. As you can tell, this isn't Dan, this is Taylor. But Dan did get out the memo before he left the office. We had and this is kind of something you may want to talk about, but Northland Health Alliance had a big meeting here, a visioning session that had probably 60 people in this room. And it was a well-attended meeting with lots of stakeholders through the community, talking about the community health improvement plan and what health will look like in Platte County. I'd say it was a successful meeting. We already met Maggie. We had a staff appreciation luncheon on June 26th. I think people had a good time with lunch, although that was also our staff meeting. So I guess during lunch, they had to listen to me recap the board meeting and talk about stuff that was probably not always that exciting. Go ahead, scroll down. We did get some more money through our maternal and child health contract, about $4,118. And they actually contacted us to see if we wanted more. We sent them a wish list. Do you remember how much it was? It was way more than 4,000. It was probably like $30,000 worth of stuff. We'll see what they say. I think we can go.
So Andrew, what does that mean that we have to, so if we don't spend it, we lose it, or what are they trying to say?
Yes, but we will spend it. We've already have it earmarked. There won't be any issue. When we submitted the budget, we already knew we would have things to spend it on.
Okay.
Scroll through. I think your report should be nice. Oh, Dustin.
So I'll just go ahead while there it is. So as Andrew spoke earlier, still working on a lot of stuff for the family healthcare transition. Like I said, we got the letters written, sending those out, information on our website. So we're moving things as long as fast as we can on our end. We do have our plans in place. I think Dr. Parker will be here covering for Janice and seeing her patients for that continuation of care on Monday, Wednesdays, and Fridays throughout most of August, and then we plan to have that little 2-week gap just to allow us to get everything set up on our end and move our supplies over and allow for Swope to come in and get their stuff set up. Hoping for smooth transition with that. We're still trying to have a few discussions with, I think one of the biggest holdups they have is like providing their own vaccines versus utilizing us for that. So we're still trying to navigate some of that. But hopefully we'll come to a good agreement here pretty soon. With the social committee, been working on trying to get staff uniforms. We're trying to have something just more universal when we do our big events. Like we have our drive-through flu clinics we do each year. We have the back to school fair coming up. It'd just be something nice to have representative of just everyone in a solid uniform that's easy to identify who we are and what we're doing, especially for big community events and outreach. We currently working on demos with different AMR system because as we spoke earlier, Sonar has been a lot of fun to work with, but there are other options out there available. And recent graduation of the Emergency Leaders Academy, I was a little bit of a humble brag here. I was actually kind of surprised our instructor actually liked my portfolio and was actually using that into future classes as examples of something you can do. I just made business cards, had a little QR code that linked it to a website. So never saw that before, so she was pretty impressed. Still visiting with our MSN student for her class. She's working on redesigning our website for STI education, try to get more outreach for all of our patients out there and try to help with health literacy for that group and better access to care with that. And that's a lot of the big stuff we have going on right now. Still working with harvesters. Our staff's doing that each month. Everyone really loves it. Everyone's looking forward to the back to school fair. I think we had about 65 physicals. 65 physicals signed up for on back to school fair, and then probably about a dozen or so immunizations scheduled already for that day. So we're looking forward to that. And if you have any questions, feel free to. Oh, I do also have WIC does have a billboard set up out by Northwest Prairie View Road and near Northwest Berry Road. Here's a little sample of it. If you guys want to see it, I'll pass it around too.
It's bigger than that.
Yeah. This is the Ant-Man size version.
That's it.
The number's updated. This is last year's model, with our old phone number.
Quality model right there. Yep.
Hopefully that doesn't happen on the license side.
We paid extra, so it went at, so. Yeah, that's all I've got. That's one of any questions, right?
Alright, so as far as accreditation, I made a bit of a life size, like, not a life size. A high level overview, Gantt chart of kind of the big lifts. So this isn't everything for accreditation, these are just the big projects, long-term things. So we're currently working on the community health assessment. As previously mentioned, we'll be doing that through the rest of the year, which will then lead into the community health improvement plan from January to May of next year. We also are going to be working on updating our emergency operations and continuity of operations plan, and that'll be through September through January. Going to be working on our risk communication strategy, September through December. And then we're working on a communication strategy to promote public health. Looks like that got cut off. But starting now through October. And then we're going to be working on workforce development planning from September, probably through June of next year. And then performance management and quality improvement starting in August and also going through June of next year. And then we'll be starting our strategic planning at the beginning of the year and also going through June. Any questions on that? Yeah, just attended a few different trainings and different things. Andrew kind of already mentioned community health assessment. We had that big visioning session. That was a pretty successful event. It was really great to get community organizations all together and kind of get their perspective of the community and figure out where we need to go going forward. We're currently working on a community survey, which should be ready by the end of this month. So we'll be having that out and promoting that as well. And then we're going to be starting to do community forums and focus groups and individual interviews as part of that community health assessment process. Questions?
So I have one thing I'll bring up. So last night, I believe about 8 o'clock, I got a call from Paul Lininger, who's the operations manager for American Medical Response, who has ambulance service. They have a West Platte location. And so just to keep anonymity, that's who I got my call from, but police and fire from one of our jurisdictions had responded to a house. The patient there, 30-year-old female, actually expired from a heart attack. And so the person's age was a concern. And the way I heard it at first was they had traveled to Africa. Well, it turns out the person actually was from Africa, had blood in their sputum, had a lot of vomiting. A lot of people's concern went up about infectious disease. And so basically, since about 8 o'clock last night, Taylor and her team have been busy working with that jurisdiction's police department, that jurisdiction's fire department, the contracted medical examiner who is actually in Wyandotte County on the Kansas City, Kansas side. So that brought in Kansas Department of Health and Environment, brought in the Missouri Department of Health and Senior Services. Of course, all of us, KU is kind of KU Med Center, and their infectious disease folks are the ones who contract with AMR and the Frontier Forensics, I think is
Yes.
the name
It's
of it.
now forensic medical, she said.
Okay. Anyway, so we had a call this morning at like 10:30. There must have been 25, 30 people. It was a lot of people. A lot of expertise coming to the table because this person ends up was from Africa. Dustin's, apparently you cannot go get an antigen test for hemorrhagic fevers just at CVS or Walgreens. Who knew? They don't let you sell those things. But anyway, it was really a great exercise. Ended with CDC's consult and kind of where we were at, some of the background of this person and their pregnancy status and they had been exposed to malaria and were currently under treatment and had a history of heart disease and different things. So but part of the problem, and I know most of you have had this happen professionally, when you only talk to like one person or only two people talk, they only get part of the story. And then two other people talk and they have other parts of the story. So like last night, some things kind of went back and forth about where we were going. And when I was talking to Paul, he's like, do you think we need to get everyone together? And I'm like, yes, because I'm just so confused about who's doing what and what the story is. No one has a complete history. No one has talked to all the players. So, and Taylor and her team were confused about what's going on. So today at 10:30, lots of things were uncovered, really gave us a clear direction. Everyone cooperated very well. There wasn't any infighting, but there were a lot of really smart people on the phone. But I think it was just a great example of whatever that preparedness that we work on and just trying to be good communicators. It happens that I've known Paul for probably 15, 16 years, ever since he went to AMR Independence, which is where he is based out of. So that's where I was a director at one point. So I'd worked with him really closely. Whenever you have a trusted colleague that you've worked with, that always helps those situations. But kudos to the entire team here, from Cindy walking in this morning, getting everyone's calling, wanting to talk about, this possible exposure or whatever we were calling it.
Was there a final conclusion?
So we're still waiting for the results from
the lab?
autopsy, but the
Yeah.
CDC determined that we don't need to quarantine anyone.
Okay.
And we're currently just monitoring for symptoms for anyone who was exposed.
How long had this person been in our community?
Less than 24 hours,
And they just travel on a plane.
yeah.
Perfect.
So you've got a pregnant female coughing up blood who might have thrown a pulmonary embolism and gone to cardiac arrest.
Oh,
Yeah, our physician on the call,
Yeah.
it's like their first thought was.
so are you trying to get a medal? Like that was
Do not take your hat off to me, because that's my
Yeah.
job every day. You put together the facts, you look at the most likelies, and then you
Well,
rule
we
them out.
were, yeah, so that was exactly the
And
conversation.
of course, it's not zebras.
But
Yeah.
but
But
before
in your
that,
position,
right, and
zebras,
before
worst
that,
case scenario.
lots of, with all the different discussions and only having part of the facts, you didn't have enough to get to that.
They'll have their answer at close point.
Yeah.
So I think whenever we spoke, the travel time, I don't think I had that, or like the fact that there was the debate about her cardiac history, hypertensive, things like that. So it was a really good example of like public health and working together. And it's like, man, I wish the public saw this portion of it, and just better frame.
Well,
what
for
we
what it's
really
worth,
do.
a colleague of mine, back around 2000, was in New York at the time, and he was an ultrasound guru. He was really, they went out to JFK and paid people getting off of international flights to do ultrasound on their legs. And they were able to determine that it takes a minimum of about 4 to 5 hours for the average person to clot. And they found a lot of asymptomatic blood clots in people's legs on trips of 6 hours or more. That was hard data. So it's interesting how this plays out. So I guess we digress. Should we proceed?
So I just thought the board would find
Yes.
that
That's very
scenario interesting and wanted to make sure everyone on the team had,
It sounds
nearly
like
everyone here had a role.
that this team did a phenomenal job looking out for the interests of the citizens of Platte County, making sure that there was no action that needed to be performed.
And as you can imagine, some of the first responders had some high levels of anxiety.
Absolutely.
And just trying to make sure that we're doing the right thing, but not ringing alarms that don't need to be rung, but not just saying, oh, it's probably this and that's good enough, because no one wanted that either. Cindy, anything on the financials? Do we have, do need a motion from the board to approve the bills?
I move that we approve the bills
I
for the
second that.
month of
Zach seconds. Anyone concerned if we go ahead and go straight to a vote then? Okay, hearing no concerns, Susan?
yes,
Kim?
yes.
Michael, yes. Zach?
Yes.
Dr. Kingsley?
Yes.
Okay, unanimous.
Any fee resolution? So we will move on to the next thing, and hopefully you had a chance to see it in your packet. And that is the employee satisfaction survey for 2024. So last year in 2023, we did our first employee satisfaction survey. And one of the things that the board discussed was, Andrew, we should do this every year so we can see longitudinally where we're heading. And we did actually talk about this in finance committee just a little bit, because as you know, one of the things we did last year in the budget for this year was to do some market study and kind of raise simply the lower paid positions up to market rate. Scroll there. I won't go through everything. In general, the trend was we were a little lower this year than we were last year in most places, except for the salary. And that was relatively the same, maybe slightly improved. For the most part, we had a little less positive and more neutral. And so staff had actually discussed why that might be. And there was multiple reasons. But I think one of the big things was change. And some of the things with like family health care and different things, I think we have great staff throughout the department, great staff in family health care, and some of that change has just been difficult for people. But we will continue to do this. I think communication was, if you read the survey, communication was one area that was mentioned multiple times. And we'll be talking with the management team on how we can do things better. But we hear anecdotal things that aren't in the survey. And I think one of the things that I have heard multiple times is we want to know where we are with family health care. We want to know when that's going to happen. We want to know the date certain that such and such is not going to be here.
They can come to the board meeting? I'm kidding, I'm kidding. I'm
So
kidding.
that actually is something Dr. Kingsley suggested we capture in upcoming surveys is how many people watch the board meeting. When Dr. Kingsley and I usually meet before this meeting, and so one of the things we talked about was, the communication issues, and he's like, we're pretty well, not to jump onto your platform, but transparency, right?
Good for everybody.
We talk about the things that, in general, the health department, the direction, and there's, if we have the date, we'll discuss it. But also, if you look at where we were every month from last September to this year, we talked about where we were going and how this is headed. But sometimes staff, they don't get that immediate answer to this is how it's going to be in 7 months. Well, we don't always have that answer. So sometimes, for me, I don't want to give people false hope or incorrect information and then have to eat that later. And so to them, it's like we're not disclosing things, but we don't have it to disclose yet, if that makes sense.
If I could digress for a second, remind me, did we build in the pay structure COLA increases or some increases that were tied to inflationary parameters?
So a COLA was for everybody,
Right.
and that was 3% this year. And then so everyone got a 3%. And then depending where you were on the pay scale and what your position was, people got up to like a 13.5% rate.
And we based that upon comparisons to other locations.
Median pay for about 8 different health departments throughout the state.
And so we were justified in that move. And I just want to be sure, if I remember correctly, we do have something built in to keep this from getting behind again.
And our friend Maggie is going to be updating the pay again this year, so we can come back to the board and say, it's really moved or it hasn't really moved. We're still we'll have a recommendation before budget time about where if anything we need to do.
Right.
My guess is we will probably need to make some adjustments. Again, I think it will be in that lower tier of the pay scale.
Sure.
Just to retain competitiveness.
But also to be reasonable and fair with our contemporaries.
Right.
Because it's important. You can't, when you do a survey like this, everybody will say, oh, we're not paid enough, which, that's going to be at any place you run a survey. However, if we have some documentation that we're at least close to our contemporaries, that's foundational for us. And
right.
Then we need to keep that up, because we could be the highest paying and everybody would say, oh, we should get paid more. Well, that's sort of the human experience, but there were.
Or they would say the pay is better, but our benefits are horrible, or the benefits are great, but the pay is horrible. So we need to find a fine line between the two that gives everybody what they need, that doesn't break the bank in the process.
I presume the comments will all be reviewed with the management team, that especially the ones that were potentially mentioning issues about age, etc. I presume you're going to be all over that. And that's all I need is a yes. To whatever degree is necessary.
Will be, may not be actually correct, have already been, yes.
Thank you. I figured as much. When I read through them, I made a note.
And so the age thing was actually more about existing senior staff that have been here a long time versus new staff rather than age. The person wrote it like it could be interpreted either way.
Okay.
But we actually, when we delved into it, it was more like staff that have been here like 15 years versus staff that have been here like 15 days or
Like
15
longevity of it.
The length of service.
Well,
Yeah.
as a board member, I'm sure my colleagues here can concur that when you read through that, our responsibility is to make sure, okay, you guys saw it and you have some action items.
So
steps.
Dr. Kingsley,
Yeah.
I think that was one of the first things he asked me. He's like, what's with this like age discrimination?
I know, I'm like,
And,
okay,
you know,
we've got
I'm
some
like,
work to
no,
do.
I don't think that's exactly what they meant.
Yeah, well,
Oh, I know a good HR attorney.
do you do an action plan of like in full employees input and put it out? Kind of,
Going to be working on a workforce development plan, and strategic planning, and this will be a portion of both.
because that's something we do at our job every year.
So strategic planning, when it pulls all employees into a sort of, if you will, a kind of a one-day seminar with leaders who put together activities, and it essentially, it's critically important to get the information, but also it affords them an opportunity to have that their voice is heard. They can see the process working. That is as much anything that helps calm nerves.
Well, and one of the things I've talked to at least a couple of the folks here, you know, on some of these projects, sometimes, you know, Dustin or Taylor may feel like, oh, I can't give Kim another thing to do. Well, depending on what it is, and maybe it's some slope related thing or whatever, sometimes it's actually going to be better to include Kim to do some of the work. So, you know, maybe we can't tell her the day certain that people are going to be walking in or whatever, but she'll have known that one piece that she worked on and how that is working and kind of see behind the curtain what's going on and just inclusivity. And that's some of the things we're going to be working on, but there's going to be a lot. When we did our pre-assessment for accreditation, the whole employee, what's it called? The
readiness assessment.
but the employee portion of it, everything in building a competent public health workforce that we have to do, a lot of these things are exactly what you're talking about.
The other thing, Andrew, that you and I talked about also is even if you get asked to do opportunities above and beyond your quote job title, those are opportunities that improve your advancement in the future, right? You're being exposed to things that might pay off for you later on. So I know some people, they probably feel like, you know, like, why do I have to do that if I'm not going to get paid for it? But to me, I look at it more, it's more of a career advancing opportunity that if a position opens up and they need someone that has that experience, you've had that experience because you've done those things. So I think that needs to be kind of stressed as well.
Businesses in their job descriptions always end the
Other
job description with and other duties as assigned, as needed / assigned.
I'm pretty sure all of ours have that listed.
Yeah.
So it's interesting. One of the things I told Dr. Kingsley, I always tell anyone I'm trying to mentor or anyone I'm trying to help move along in their career path, I always tell them, do the things in your current job that are required of the next job that you want. So if you are a programmatic person and you want to be a supervisor, start doing those things now. Anytime you get that opportunity to do that next thing, do it. It's interesting, one of the comments was exactly opposite of that. They said, if you don't get paid for it, why would you ever do it? You know, my bosses just keep giving me these opportunities or these tasks that aren't my normal job. Well, yes, I'm trying to see if you're ready, if you're the person we're going to mold for that next step in your career. And for me, when people don't want that opportunity or they don't want to do that, I'm like, well, Dustin's over here doing all those things. It's pretty clear when that next job opens up above him, he's already doing it. I already know he's excellent. I may need to open it up to everybody or whatever the situation is, but when he walks in, he's probably going to be pretty prepared because he's already done the job. So
Instead of looking at it as an impediment, I think it was it's more strategic to allow you to advance in your career. I mean, it's all about reframing how you do things, I guess.
But they will sometimes see it how they want to see it. So
It's perception. A lot of it's perception.
So I believe that is everything I wanted to discuss there. We will continue that. We will work on the pay scale info and bring that back at a later meeting.
All right.
And I don't believe we have any public comments unless, Maggie, you want to say something really nice about Dustin?
I would like to point out the 5-year average. I always read thoroughly this, and the TB cases uptick is substantial, significant. It's just not Platte County. My wife, Dr. Isom, was just exposed 2 nights ago to an active TB case. And when I see, is it 29 cases this year when we average, the 5-year average was 12 cases per year. It's in the packet. It's a substantial uptick, just making sure that it's not overlooked as a concern, and that whatever coordination we might need to do to consider offering or putting out something on the website or something else to say, get TB tested. I know all of our daycares require TB testing and some other things, but I am concerned as a trustee that I see that uptick from a medical standpoint. This is what you see before things get pretty rough.
So one thing, a few months ago, you brought up a concern about flu. And we actually came back and presented, and I actually thought Taylor and her staff did a great job.
Yeah, I concur.
And I thought it was actually very informative just for the board, but for the public, anyone who's listening in, Taylor, I'd actually love if you guys just put together, it doesn't need to be a documentary about TV.
I'm not making work for you. I have to do this because when I see that sort of an increase over last year, we had, was it 5?
So let me just clarify one
Yeah,
thing too.
please,
So
please,
the
please.
things that are listed here, that doesn't necessarily mean that those are all cases. That's just who we come into contact with. So some of them are like, we determined that they were not actually a case.
Okay.
It's just
Not
like we're
active.
getting information about it. And so sometimes we get information multiple times, so it makes it seem like it's higher, but those aren't the actual like necessarily cases of it.
Okay.
It's just those are the investigations that we did.
Oh, I'm sorry, I read too fast.
I think we maybe need to like revamp how it's done, because I think that is kind of not very clear.
I made the same assumption. So
Yeah, so I think.
Thank
we're
you for the
gonna talk about
clarification, Ben.
revamping that.
Great.
Some of them are.
That makes sense. If the numbers were not just investigations, but actual cases, I think I was right to raise a concern.
Sure. So
I will clarify with the exact number of actual TB cases that we have had, if we can bring that back for next time.
So maybe next time, just kind of reword this and then we can explain what we've changed or what it actually means.
Because the state may not look at it with as much concern and eyebrow raising as we do if we see it upticking. And I'm sure they have thresholds and other items to consider, but I just wanted us to be sure we're not just going, oh, well, that's interesting. But communicable diseases, especially TB, I mean, it's curable. But we don't want to get the types that are 3-drug resistant.
Yeah. So part of the problem with the report, and it's just evolved over the years, but the report is supposed to do two purposes, and that show disease in the community, which you're talking about. But the other thing it's supposed to do is show staff activity, so you all know what we're doing all month, not just eating bonbons. Like
I think
and so I
DHSS,
think that's kind of what
the
needs to be
actual cases
clarified.
are on the DHSS website, just like flu. They should be because it's reportable.
Right. So we'll
Thank you.
clarify that.
All right. Is there any objection to us going ahead and entertaining a motion to move into closed session? Hearing no objections, I would.
Do the finance committee report.
Oh, sorry.
We didn't.
Come on. All right.
I have it here.
Okay, I didn't know if you wanted to skip that or if that was just
We
an
can-
error on your part.
I didn't mean to skip it.
Oh,
That was an error, but
okay.
thank you for pointing out my error.
Would you, provide us your presentation on the finance
Okay,
committee,
well,
please?
we'll do it a short one here. The finance committee met on Tuesday, July 9. And we, basically are kind of starting to work on an investment policy. And we had an in-service, from Angie Hughes, I think that's her name,
Yes,
about Missouri Securities investment programs and rates. And it was one presentation, but it got us started in terms of what we need to start kind of looking at. But basically, if we look at this in terms of our reserve accounts and what type of interest rates we want to get, this would give us a higher interest rate if we kind of went toward that. But we're kind of looking, we're just at the beginning processes. Do you want to add
So,
to that?
I'll just add a little bit.
Yes,
So,
thank you.
I talked to Jen about creating a investment policy for us, because before any public entity invest anything, they actually have to have a written policy. For the most part, we kind of adopted what the state secretary of state or
State treasurers.
state treasurer, sorry, state treasurer, basically they have a template. And so for the most part, that's what we have. This upcoming meeting for August, Jen is actually going to come talk to us about the plan that she has put in a draft form, so we can hopefully finalize that and bring that back to the board. The other thing is that I had no idea, Angela's company, Missouri
Securities investment program.
MSIP, I think,
Yeah,
or something, MOSIP, there's actually only one company that does this. And because there's multiple companies, we'll be needing to talk to Jen about what's an RFP look like? What do we have to do to put this out there? I think what impressed me was right now, they have multiple different plans. Their most liquid plan, so anytime you put in money, you can get it out the next day. That plan is about a 5.22 investment or percentage investment
yes.
interest rate.
Mhm.
And that's more than what we're currently getting. So essentially it's the same kind of product.
So the current rate we're getting right now, Andrew, is what, 4.66? Is that what it was?
Oh, it was 4.7, 4.73%.
Yes,
So
June.
that's a big jump. So that'd be nice. Okay, so sorry, keep going. I was just curious.
And so that's what I think for the most part, everyone on the committee kind of looked at is there is a way to you know, especially now that we're going to have these reserve funds, we want them to grow as quickly as possible. And whatever mechanism is safe. And there's all kinds of rules and regulations that we can't go to the casino and put it all on red. Susan said I couldn't, so, and then Jen backed her up. So we can't do those things here. But we want to, you know, as much as we can, optimize the yield at the same time. And Dr. Kingsley and I talked about that. The finance committee has talked about that extensively. So I'd say probably within the next 3 months, hopefully we'll have our funds in a situation that we are optimizing what we get back.
So Andrew, remind me in our discussions, are we waiting, like we're going to take bids from different choices, or how are we getting the actual options to choose from?
So next month, we will be talking to Jen to finalize our investment strategy, because we really can't do our investment
So you have a
policy,
Yes.
because we can't do anything till that's finalized by the board. So hopefully we'll have that for board consideration next month. But then Jen is going to guide us on what an RFP looks like and what we need to do. And so hopefully those things will kind of happen just bang, bang, one after the other.
Sounds good.
And
Great
then
report.
also, I think you and I talked about, what are the parameters? Like, is there penalties for taking out money too soon, or how long are you supposed to leave it in? Depending on, like, if there's an emergency and we need access to money, what would be the penalty if we took it out within a day, or if we have to wait 2 weeks or whatever? So we need kind of a breakdown also on what the parameters are for each investment vehicle.
So, and just to give everyone a kind of sneak preview, that 5.22% rate, that is their most liquid vehicle. So that is, I call tonight, I have the money tomorrow.
These,
One of the things, since I'm not part of the committee, I would make sure to work into your policy that someone keeps an eye on those sorts of funds, because those will change rapidly as well. And sometimes they will drop below other vehicles that are within the parameters of the state that you guys could make a change. So I would suggest you guys consider having a line in there about this will be monitored periodically.
And I think our plan is to monitor it every month during the meeting.
probably, yeah.
Fair enough. Okay,
I mean,
Good
I
enough.
think that was one of the things we wanted to be able to do is have these different, if we use some sort of vehicle, that we have some.
all right. Anyone else have
Right.
anything that's not on the agenda? Maggie, anything? All right. Well, hearing none, I would entertain a motion to go into closed session.
Motion to close the session.
Zach makes a motion.
Do we have to
go
close
We
it?
do need
Yeah,
to
you have to say the spiel.
executive session.
All right, motion to close the executive session, in pursuant to 610.02 and RSMO 2000. Camera and microphone will be turned on when regular session resumes.
Is there a second?
A second.
Kim seconds. Roll call.
Yes.
Susan, Kim,
Yes.
Michael's yes, Zach,
Yes.
yes, Jeff.
Yes.
All right, then let's go ahead and turn off the microphone and move into executive
Okay.
session.
I actually have my computer on and my cell phone on, so I should state on Dr. Kingsley's computer and then Dr. Kingsley's
Gotcha.
cell phone or whatever. Make sure those
Okay.
stay on.